Hi, everyone. I'm Molly Collins. I'm joined today by Noah Lieberman, and our PI is Dr. Griesenauer. We'll be discussing the role of tissue plasminogen activator, or tPA, in the context of large vessel acute ischemic stroke. And we have no disclosures. Patients experiencing acute ischemic stroke can undergo various treatment modes. For our study, we focused on the administration of intravenous tPA, which causes clot breakdown. And as we'll discuss today, patients with large vessel occlusion, acute ischemic stroke, ultimately undergo mechanical thrombectomy to restore blood flow. But in recent years, tPA as a bridging therapy is under evaluation. In our retrospective review, we aim to determine the effect of tPA on functional outcome at 90 days for these patients. And as our work is ongoing, we'd like to frame our study with an overview of acute ischemic stroke and the many variables that we consider as we aim to describe the relationship between tPA and functional outcome. Ischemic stroke involves the blockage of a cerebral artery, which can be devastating for the patient. These statistics here highlight the prevalence of various disabilities suffered by patients of AIS. So this is truly the crux of our study, disability or functional outcome.
So the goal of mechanical thrombectomy for stroke patients is to prevent the penumbra from growing and killing more brain tissue. If reperfusion occurs quickly, then that penumbra can be recovered. And that's what makes a quick intervention so essential, because rapid intervention can save brain tissue and prevent further disability down the line.
All right, so to review neurovascular anatomy, I'd just like to briefly emphasize that there is a distinction in the anterior intracranial circulation versus posterior. Proximity to critical structures like the brainstem can make these posterior circulation strokes particularly disastrous. And this is something that we definitely take note of when we compare cohorts to really develop a fair and accurate model for tPA and thrombectomy outcome. And to the right here, we have an example of what a thrombus looks like in the basilar artery on imaging, and then what that looks like when blood flow is restored post-thrombectomy.
So our study focused on patients with large vessel occlusion, which makes up 35 to 40% of ischemic strokes, and that can involve blockage of any of the major cerebral arteries listed here. And the large vessel occlusion can extend from the carotid bulb or vertebral artery, and it can also involve tandem occlusion, which involves both intracranial and extracranial occlusion. And large vessel occlusion is a type of stroke that is very severe and can impair higher order brain function if left untreated. And another part of our project involved collecting data on the type of stroke that patients experienced. This involved collecting data on the location, as in the artery affected, the side of the stroke, as well as whether it was tandem occlusion or not. We also looked at the etiology, or the cause of the stroke, and this involved gathering data on the TOAST classification, which contains 5 subtypes of etiology for acute ischemic stroke. As you can see listed here, large artery atherosclerosis, cardioembolism, small vessel occlusion, other, and unknown. And the stroke, or the TOAST classification system, can be very useful in predicting the prognosis, as well as the outcome and future management steps for stroke patients.
So if we imagine a patient en route to a comprehensive stroke center, there are many diagnostic steps and metrics involved, and one that's commonly used to assess patients upon presentation is the NIH stroke scale, which we collected in the first few post-operative days as well. It's a relatively detailed assessment that can help to predict whether the patient's stroke is actually the result of a large vessel occlusion. But this is the big one, the MRS. It is the primary clinical outcome measure for the degree of disability in stroke patients, recorded at baseline and again at 90 days. And you'll see this scale again as we review our preliminary analysis of both tPA and non-tPA cohorts.
So currently, researchers are trying to ascertain which variables have the strongest relationship with stroke outcome. So as you can see from these articles, our research follows that trend, because we're testing the relationship between our data and different stroke outcomes that patients can have. So this flowchart is just an example of one guideline the hospital might use in treating patients with acute ischemic stroke. So this particular one uses time from onset, as well as NIH stroke scale scores to determine the course of intervention for an acute ischemic stroke patient.
Following tPA administration, if not otherwise contraindicated, patients undergo mechanical thrombectomy for large vessel occlusion. And this can involve a range of devices, including stent retrievers, such as the solitaire, which is shown below, an aspiration catheter, or both. And so this has been an important piece of our data collection to determine which patients received precisely what treatment modality under the umbrella of mechanical thrombectomy. So how did the current algorithms arise for tPA? It's interesting to note the relationship between stroke reperfusion strategy and cardiac guidelines, as those guidelines are now actually preferring mechanical intervention over fibrinolytics for shorter treatment delays. The stroke model, which is currently designed to deliver tPA, may actually follow suit. Certainly there's a beneficial effect of tPA, which has been widely investigated since 1995. However, there is some momentum in recent studies that begins to call the efficacy and prioritization of tPA into question. tPA recanalization rates differ among sites of occlusion. AHA guidelines have shifted to really emphasize timeliness. And a study in 2017 postulated that mechanical thrombectomy could be initiated sooner. tPA could also increase hemorrhage risk. So our investigation into tPA and functional outcome is certainly a timely one.
So the way we carried out our study was by completing a multi-center retrospective review. So basically any Geisinger health patients that came in with acute ischemic stroke and large vessel occlusion from 2016 to 2019 were included in the study. And those that had a mechanical thrombectomy performed was also part of our inclusion criteria. All of our patients but 7, we were able to follow up with MRS scores at 90 days. And the main 2 groups we divided our patients into was those that received tPA and those that did not. And to analyze this data, we used certain statistical tests, including the Welch's t-test, Fisher's exact test, and ANOVA. Some of the data we collected includes the age and onset, the past medical history, especially in regards to stroke risk factors, including hypertension, atrial fibrillation, diabetes, hyperlipidemia, CKD, as well as previous strokes or transient ischemic attacks, and their smoking status. We also classified the type of strokes we said previously. We also classified the surgery procedure, whether it involved a stent retriever, an aspiration catheter, maybe an angioplasty, information about the discharge, as well as some other scores such as NIH stroke scale, aspects, and TICI, which measures recanalization. However, the 2 most important data points we collected were whether they received tPA or not, and the MRS score at 90 days to show that functional outcome post-surgery.
So these are our preliminary results. A total of 301 patients of median age 72 underwent 306 mechanical thrombectomies, so some patients did have more than 1 stroke. 119 patients received IV tPA. The M1 segment of the MCA was most frequently occluded overall, which you can see in the figure there on the bottom right. And cardioembolic infarction was the most common etiology across both cohorts, which you can see there on the left. And this aligns with prior studies distribution and gives us greater confidence in the data that we gathered. Good functional outcome at 90 days, which is an MRS of 0 to 2, was achieved in 38.1% of the thrombectomies in the tPA cohort and in 28.2% in thrombectomies without tPA. Preliminary analysis indicated no significant difference in outcome between these respective cohorts, and when scores were dichotomized into good or bad functional outcomes, so a score of 0 to 2 versus 3 to 6, a 2-tailed Fisher's exact test also showed no significant difference in outcome. Preliminary single variable comparisons demonstrated no significant relationship between IV tPA and functional outcome following mechanical thrombectomy for AIS, and this does align with prior studies on the controversial role of tPA. But we're continuing now with multivariable analysis of patients stratified by baseline presentation, stroke territory, and a lot of the other variables that we've mentioned today. And this may yield differential results that can direct the course of AIS clinical management. We're continuing to unpack this data with the identification of confounders, and the wealth of information that we have allows for balanced comparisons between patients. There's also additional data collection ongoing, such as whether these patients both received tPA and had any hemorrhagic conversion of their stroke. So we have a lot to look forward to in this study, and we're eager to fully model the relationship between tPA and functional outcome post-mechanical thrombectomy. And with that, we'd like to take any questions. Thank you.